Welcome. I'm thrilled that you're here. I know that you have a lot of other places that you could be, but I'm glad that you showed up here today. And I'm going to take a moment right now to thank the Centers for Excellence in Aging and Health and the Center for Excellence in Collaborative Education for their support and their help as we got this program running. So let me see here. If you could, in the chat, could you tell us your name, which I think is in there already, and where you're from? So I can't see the chat while I've got this going, but I hope that one of my colleagues will be able to tell me that people are saying where they're coming from.
Absolutely, everyone is. And I'm so glad to see that people are putting their affiliation and or their town. And that's really, really what we're looking for in terms of where you're from. And this is Susan Weary from Biddeford speaking.
Great. So we have, while you're doing that, we're going to ask you to multitask for a brief period. And we're going to ask you 2 questions that we'll do a polling on. So the first question is, who's here? And there's some options. Lorena, are you getting the Zoom poll up?
Yes, just 1 second. People are still entering. Hold on.
So maybe we're doing more than 2 tasks at once. Maybe we're doing a whole bunch and we wish we were that Indian goddess with all of the arms.
Okay, the poll is up.
So tell us who you are.
This is Dottie Lamphere. Can you hear me?
Yep.
Okay, now I see you. Can you see me?
Maybe.
Probably not while you're screen sharing.
Well, what I'm getting is your internet connection is unstable, so that's why I'm asking.
I can't get on online. It says you've met full capacity. I pre-registered.
I don't know what that means.
You're on now, ma'am. You're on now.
No, I'm not. No, I'm just on my
Okay.
on my cell phone. I want to be on my screen.
And all right, so what I'm getting now is who's here. All right, I'm Dottie Lamphere. I live in Lincolnville, Maine, and I am a counselor.
Thanks for that.
Okay, I've had a text message from a couple of people who had the same problem that speaker was having.
It's been corrected. They just need to sign on again.
Yes, I was just going to say, Lorena, that, you know, this is one of the great lessons of Zoom, right? It brings out all of our opportunities to be patient with technology so we can take full advantage of it. And we've got a great team here from AgingME.
Okay, right.
Who are working on these various issues to help people get in. So have faith, have hope, and have
patience.
And this is Lisa Letourneau. I am in now as well.
Great, Lisa. I saw your name there in the waiting room and I thought, okay, somebody's fixing this. Trust in the higher tech power. So good to have you all here. And Dr. Solomons, back to you with your poll.
Okay, it looks like we have a whole lot of social workers, which is great. We have people who are interested in the field, some caregivers, a couple of docs and some nurses and therapists. No data or technology specialists. I guess that would just be me. So,
Nan, this is Tom. We're not seeing the poll on screen.
You're not seeing the poll. Lorena, back to you.
I see it. Other people say, I'm not sure if they have to adjust their.
It was on and now it's off.
Ah, okay. You know, it doesn't say here yet that it's ended, but I do see from Samantha a great reminder that we forgot to put in an other category.
Yeah.
Samantha is, I believe Samantha just came across my screen quickly, but I think that You may have identified as a language therapist. Apologize if I'm getting that wrong, but there are a lot of professions missing here. And so I would ask, maybe just describe yourself as a person interested in the field. And that would be super. We're really just trying, Nan, if I may, to try to create a sense of virtual community that, if we were all in the room together, some of us would be knowing each other. Some of us would be talking about what we do for work. Some of us would be talking about where we're from. We're really just trying to come together in a way that says, here are some usual things people describe. And if we've missed some, apologies. If we've not listed yours, please put it in the chat
I
box.
did. I'm on I have
Excellent.
from 9 to 1, I have an in-service.
Excellent. Okay, thank you. So
I
I'll
muted it.
keep,
We'll listen a few minutes and see.
yeah,
And
and Sharon, we're hearing you, and so I'm just going
Wanted
to
to
ask
just mute her.
people to remember to mute themselves, or I will do it if we're getting some background noise. I think, Nan, I don't know about you, but I think this is actually a great way to start a virtual conference where we get to exercise our flexibility and kind of rolling with some of the frustrations. So
Right.
again, back to you.
All right. So everybody has frustrations with technology. It's not just you. So that, I think, is a good thing, and it makes us work together to solve the problem. So I'm going to end this polling. Again, it looks like we have a whole lot of people, and we have a variety of people, and some that we didn't think to call out. So I'm thrilled that everyone is here and that it's diverse. So that is great. And now we'll go to the next. Oh, did we share the results? There you go. And I'm going to stop sharing this and go to my next question, which is, no, back up. How are you doing today? And Lorena, if you could put that poll up, we'll see if we have better luck with that.
It's the old poll.
Okay, so we have that. Can we do the next poll about how are you doing today?
It should be showing now.
Pretty close. Most people are happy to be here. Curious, engaged, ducky, and that can mean a whole lot of things. Fewer distracted, a little overwhelmed perhaps. Meh, I hope we can change that. And if you're still meh, that's okay too. Okay. So let's acknowledge it and pull out your deck chair and get comfortable. And let's begin. So curious and engaged, happy to be here, ducky, distracted, overwhelmed, meh, however you are. Let's get started. So okay, that's great. Thanks, I'm going to pull that off. And now let's go to the next one. Having issues with the PowerPoint here. So this is going to be the 20,000 foot overview of what the agenda is for today. We've done, it's going to be a packed 4 hours. We have a first plenary that will last about 40 minutes, and then we'll have a breakout room where you'll have a chance to reflect with hopefully 9 friends that you may or may not know, and we'll want you to reflect over the last year. And then at 10:45, we'll have a middle plenary on infodemics, another breakout session, and a final plenary with a group discussion and a wrap up that will go from 12:45 to 1. And then, so. Okay. Hold on a second. So we need to talk about some housekeeping. First of all, there is no intermission, so get up, move around as you need to. Make sure that you are on mute in the larger area. You can, if your name is not your full name, you won't get credit. So please use the 3 dots to the right of the mute button and change your name to your full name. You can also move the closed captioning around by hovering over the words and just moving them to a place that is better. So let's see. Take breaks as needed, get up, move around. Please be mindful of the time. Our schedule is tight and we're already over, and we don't want to leave anybody behind. So the next. If you've forgotten where the controls are for Zoom, I'm sure you're all experts now. The bottom link here, if you can see my arrow, mute and stop video if you're on a computer is here. If you click the 3 dots, you'll go into breakout rooms. If you're using a phone or an iPad, you have to tap your screen to get the mute and the stop video, and the 3 dots will get you to the chat bar if you don't know that already. And finally, we will, as I said, we'll have breakout rooms, and we'll have, because we have so many people, we'll have a few breakout rooms. In there, we'll want you first to introduce yourself. We'll want you to designate a scribe and also a timekeeper and facilitator, so you stay on task. Each breakout session will have several prompts that will be listed. We'll ask for about 2 or 3 responses for each prompt, and they will go into a word cloud eventually. And again, try to respond to all the prompts within the time that you have. There is no designated monitor in each room. We will pop in and see that you're on track, and there's also an option to ask for help. And now I get to be Ed McMahon from the Johnny Carson Show and say, I'm turning it over to Dr. Wary. And I'll stop sharing.
Thank you so much, Nan, and thank you everyone for being here. I am really looking forward to this day. I'm going to share my screen now. My name is Susan Wary, and I'm the Chief of Geriatrics, University of New England College of Osteopathic Medicine, better known to us as UNICOM. I'm also the director of AgingME, which is Maine's Geriatrics Workforce Enhancement Program. And when we first heard some months ago that the annual Bar Harbor Maine Geriatrics Conference was not going to be held again this year, we put our heads together and thought, what could we do? Because we knew that we would be wanting to see so many of you that we've worked with over the years, and that we couldn't recreate the in-person experience, but that maybe we could do something to fill the gap in knowledge. And we're thinking about, what is it we might want to be talking about at this time of year? And we realized that what we really wanted to be doing was to create an opportunity for us to come together collectively to sort of think about what we had been through, to reflect on it together, to support each other, to extract the lessons that we can extract from the pandemic so that we can go forward together with a great deal of confidence. But I got to tell you, for as excited as we were about doing this, it absolutely would not have been possible to bring it together in such a short period of time without the leadership of Dr. Solomons, the new director of the new Center for Excellence in Digital Health. And she has proven to be a great partner and friend and colleague in so many things related to our pandemic learning and to our moving forward into the future in digital health. It also would not have been possible without our project coordinator extraordinaire, Terry Faye Babcock. And Terry, I just want to thank you publicly for all that you've done behind the scenes to help make this happen. And there are many others I could thank, but those are two standouts. AdCare, the Educational Institute of Maine, is providing the support for this Zoom session. And we're also very glad to be partnering with them for the first time in an educational venture. And so I want to give a shout out to you as well. Soon I'll give a shout out to the speakers, all of whom said yes without hesitation when very late in the season for a lot of quite prominent people to be able to say yes to coming to our spring soiree. They didn't hesitate, and I thank them for the gift of their knowledge and of their time in advance. So what is AgingME? What is this Geriatric Workforce Enhancement Program? Well, it is a 5-year HRSA grant. We just ended the second year, fingers crossed for getting funding for our third year, but it's a cooperative agreement with HRSA, the Health Resource and Service Administration, that is designed to do these three things. First and foremost, in my mind, is to empower older adults to be able to be engaged effectively in our own healthcare and to engage effectively in speaking up about what matters most in terms of our healthcare goals. We also want to help create an age-capable workforce. And with our great partners at the University of Maine, we are doing just that in all disciplines that touch the health lives and the well-being lives of older adults in Maine. And then the third goal for HRSA is really to transform primary care practice so that it is focused on the so-called 4Ms, which form the backbone of an age-friendly health system, where it is asked of the older adult, what matters most to you in your healthcare? What's important to you about your medications? Do you really need all of these medications? What's important with respect to your mobility in terms of remaining active, independent, and strong, and preventing falling? And then, of course, we always pay attention to our minds to make sure that we are as mentally healthy, as free of depression, anxiety, and decrease our risk of dementia or live with our dementia well, if that is in fact what happens. The learning objectives for today, for those of you seeking CME or CEUs, is that at the end of our time together, we hope that you will be able to speak really from an educated place about the impact of this coronavirus, especially on older adults, to describe what infodemics are and how we can have an antidote to it, especially in the service of older adults. And then finally, looking forward to the future, to be able to begin our discussion or continue our discussion of the best use of digital health technologies. Now, I like to think about this virus as an unfriendly virus that did its best to upend our increasingly age-friendly state. I also like to think, despite the disproportionate impact that COVID-19 pandemic has had on older adults, both in the community in terms of isolation, in congregate living in terms of isolation, and in terms of becoming ill, and in terms of many deaths. But I like to think about Maine as having risen to the occasion and preventing this virus from truly upending us. And we've invited 4 people here this morning to help tell that story of Maine's response. And our first speaker will be Lisa Letourneau. Dr. Letourneau is a passionate advocate for health systems reform, health systems improvement, and has been at the forefront of supporting efforts, Maine's response to the COVID-19 pandemic, from testing to protection to mitigating the risk and now to the vaccines. She may need no introduction, and I'm sure that Jess Maurer needs no introduction. Jess is the very able leader and executive director of the Maine Council on Aging. And I personally could not be more impressed nor more grateful for the way Jess and the council stood up the leadership for collaborative work during the whole pandemic. It continues to happen, meeting initially every week, now every other week, soon maybe we're down to once a month, I don't remember. But the Maine Council on Aging has really spearheaded a collaborative effort that has brought together our legislators, municipalities, all of our community-based organizations, our healthcare systems, our institutions of higher education, and people who are dedicated at every end or every aspect of supporting well-being of older adults. I couldn't be more grateful nor more proud to live here and to be part of this team. Rounding out our discussion this morning will be Susan Corbett, the founder of the National Digital Equity Center, and really an eminent authority in how to cross and narrow the digital divide. And rounding up our discussion this morning is Reed Plimpton, who's the project manager for the Northeast Telehealth Resource Center. Again, another really important resource as we move forward. So with that, Lisa, I will turn it over to you, and thank you again, all of our speakers, for being here, and for our participants for preparing to listen. Thank you.
Well, thank you, Susan, and thanks everybody for joining. Lisa Letourneau, as mentioned, currently senior advisor with Maine DHHS, and before the pandemic was involved in several different initiatives, and since the pandemic, still doing those, but also it sort of falls into the duties as otherwise assigned. So helping out generally with various clinical aspects of the COVID pandemic, particularly around issues of education, clinician outreach and support, starting with testing, going through support for quarantine isolation, contact tracing, and now happily vaccination. So I like to remind everybody, I do not actually work directly for Maine CDC, and I am not in charge of anything, but I am involved in a lot of things. And when Susan and others asked me to give some highlights about the COVID pandemic in 10 minutes, I said, oh, sure, I can do that. So if I can share screen, yes, I am going to do a very brief state of the state. Is that working okay? Can you give me a thumbs up? You see this?
We can see it.
Okay, great. So the request was to touch on some of the key data points related to the COVID pandemic, which we are still, folks might be well aware, in the middle of. So it's not as though we're done by any shot, but definitely things looking better. So I, with help from some of my colleagues here at Maine CDC, pulled together a couple slides to try to highlight some of the big data points here. So first of all, and of course, as you know, this data is only as good as the date that is presented because it changes every single day. But as of now, 2 days ago, May 18th, we had a total of just over 66,300 cases in Maine, sadly, just over 800 deaths, close to 2,000 hospitalizations, and importantly, perhaps for the topic of this symposium, many outbreaks, 153 in long-term care facilities, particularly in the earlier days of the pandemic. I'm very, very happy to say that those have gone down dramatically with vaccination. I'm also very pleased to say that our colleagues at DHHS have done a great job, I think, in making some of this data available on the CDC and our DHHS website. So I've, wherever I can here, wherever I could put it into the slide, I've included the link, and the UNE folks have these slides, so happy to share these. And again, this data is updated every single day. So first, looking at cases, both in terms of the change over time. This goes back to March 1. So if we saw the early days, excuse me, this is the early days, I'm sorry, from March 2020. So almost a year and a half ago now, we saw cases poking along, and then we know the fall, and just similarly to nationally, right? Things really shot up. in the fall, and whether that was due to holiday gatherings or the natural seasonality of the virus, we don't really know. We saw in Maine actually a significant second, or some people would even say third surge. We sort of had November, December, and then following March and April, another surge that was pretty sizable, and luckily that is looking better now. We also see on the left-hand side differences by county here in terms of cases per 10,000 people. And all along in the state, this has been the higher cases in more populated areas, again, not unlike other areas of the country. And so the southern counties, although it has certainly found its way into the northern counties and more rural counties as well. You can again see the trends here from some of the hospital-related data. So ER visits for things that looked like COVID. And interestingly, and as you probably all know, we've seen very few other things that look like COVID. We had almost zero flu season here in Maine. And I suspect that many of you on the call, like me, have had not even a cold, knock on wood, if you've been fortunate enough to avoid COVID over the past year. And that's largely due to those basics of social distancing, masking, and hand washing. And I think many of us will carry some of those lessons with us, hopefully. We don't have to get a cold every year. We don't have to get the flu every year, and hopefully we don't have to get COVID. So you can see similarly starting in March, a lot of people initially with ED visits as symptoms started, and then those spikes again in November and March of this year, and then hospitalizations. And we know that hospitalizations always lag cases by 2 to 3 weeks. So you see those spikes, and luckily we're starting to see a flattening of that again from the last round. Again, the county data, you can see here just a little bit closer look. So that same map I showed before, but then with these bar graphs, again, in the more populated counties, up until now, York had been one of the hardest hit. Cumberland, interestingly, Oxford picking up, and then Androscoggin has been a huge part of this most recent surge, sadly, and you can see that here. In the early days, we certainly had a disproportionate occurrence of cases in some of the communities that were diverse, many of who worked in frontline employment situations, whether that was healthcare, long-term care, meatpacking factories where people were close together, frontline service industries. But in this latest surge in Androscoggin, it's sort of been all over the place, and definitely an older, more rural white population as well. You can see the hospitalization data here, and unfortunately, again, Androscoggin has jumped up. Oxford has been interestingly high as well. And then the state has gone further and broken it down by zip code. So again, this data is available. I didn't have room for that link. It's the same link, just kind of different tabs. Actually, this one is a separate file on the DHHS website. And you can see, again, a lot of that clustering of zip codes within counties with higher numbers of cases. And that's sort of following the I-95 corridor as well, with some high spots, unfortunately, in some of the more rural counties, you can see. So that's the challenging part, certainly has been the cases, hospitalizations, and deaths. The good news is that Maine really has been a leader in vaccination. So you can see we share this data also on the governor's COVID vaccination webpage. Just over 1.3 million doses administered now. Now we have 1.3 million people in the state, but that's first and second doses as well. So, but that reflects into just over 50%. So over 57% of the population has received their first dose, and close to 55% of the population final dose. In certain populations, it's even considerably higher than that. I don't think I have a slide, but maybe do I have a slide? I don't think I have a slide, but when I looked up the data, it is over 80%, maybe it's on my last slide, sorry, over 80% of the population 60 and over. So for 80 and over, I believe it's 83%. For 70 and older, it's 82%, and 60 and older is like 79%. So averaged for 60 and over, it's just over 80%. So that's pretty remarkable, completed vaccination. And thankfully, again, we are seeing the impact of that in the older community with far fewer outbreaks in long-term care facilities and far fewer deaths in older adults, even though older adults continue to bear a considerably disproportionately high share of deaths overall. Yay for vaccinations. The DHHS also has this COVID vaccine dashboard where this data is regularly updated. So you can see some of the details here by gender, by age group, and first and final doses, and then broken down by race and ethnicity as well. We have been doing relatively well, I would say, in some of the diverse communities, but particularly as we move into younger populations, that is a big challenge, both in white and people of color communities. So we certainly have a lot of work there, as you probably all know as well. With the Pfizer emergency use authorization recently extended to children in the younger age group. So it was down to age 16 before, and now the younger age groups, that is a real challenge to start getting that vaccine more widely uptake throughout those younger populations. And just as we saw differences by county and by zip code with case rates for COVID infections, we see some really interesting differences by zip code as well. So here, the yellow and the red, excuse me, the yellow and the red are the lower rates. So the texting here is right over it. Green is more than 60% of residents are vaccinated, and less than 2,000 residents in that zip code remain unvaccinated. The blue is that 60% are vaccinated, less than 60%. So basically the green is better and the red is better. It's really tiny. So some real gaps still in terms of areas. And again, interesting gaps in a lot of rural areas of our county, of our state, different by different counties and zip codes, and in certain, I think, reflecting cultural differences in urban communities as well. So interesting data, and I think really compelling in terms of what that could mean to community leaders, to clinicians, in terms of trying to address some of those gaps. And then in terms of some bright spots as well, using data from the Kaiser Family Foundation, and there's others that keep these different dashboards or trackers as well. I think overall, Maine really has done quite well through the hard work of so many partners around the state, and I'm sure many of you on the call as well. So we are currently ranking the 4th lowest in terms of both the total number of deaths and the deaths per 100,000 population. 5th lowest in terms of number of cases per 100,000 population. We are bouncing back and forth in tight competition with our Northern New England neighbors as one of the top 5 states for the percent of population vaccinated. Some days you'll hear Dr. Shaw say we're number 1, and then New Hampshire beats us or Vermont moves ahead. So it's literally neck and neck. Interestingly, Northern New England is absolutely remains in the top for the country nationwide. I mentioned this statistic, 80% of people 60 and older are fully vaccinated, more than 80%. And I think a huge part of this is due to the very high levels of collaboration and private-public partnerships in the state. You know, if you look at those numbers and think about the public health infrastructure we have in Maine, it's pretty stunning because we don't have a highly decentralized public health infrastructure that many times, you know, I think states look to deal with public health emergencies. I would say like this, but we've never had one like this, but for other public health emergencies. Haven't had one in our lifetime, at least. But as many of you probably know, many, probably most other states have county health departments where they have actual people on the ground providing care, doing testing, in this case, you know, giving shots at the county level and sometimes at the city level. In Maine, the public health infrastructure, through an interesting, you know, set of historical circumstances, is highly centralized, is in Augusta. We have 2 relatively small public health departments in Bangor and Portland, but even those have really faced a lot of challenges over the last decade or so with funding cuts. We have public health nurses, but if you've read the headlines, you know, the numbers have been way down since the last administration. So for this kind of work, we really have relied on partnerships with the hospitals, with the health systems in the state, with providers, community groups, schools, and they have stepped up in a big way. So I think there's a lot to be applauded, and a lot of that is the work that's only made possible because of the hugely collaborative nature of the state and the hard work that so many partners have done. So with that, I may have gone over my time. I will stop talking.
Thank you so much, Lisa. I don't know if you've gone over your time or under your time, but that was the perfect amount of information. And I'll turn it over to Jess now, if I may, to
Yes. Oh, I just took some of Jess's time. That's okay.
Oh, yeah, no problem.
and, Jess,
Jess.
you can continue this theme of the power of collaboration.
You're funny. Anyway, thanks to Dr. Letourneau and to all of our state officials for all of the incredible work they have done over the last 16 months. Geez, I just don't know. And you all have worked so hard and done so much. You're responsible for those numbers. So thank you for everything you've done. Really phenomenal, as Susan Leary says. Exactly right. So I'm really pleased to be here with you all, and I will apologize right up front to say that I'm going to have to take leave right after this because the Appropriations Committee has just started meeting, and I need to go over there and provide some testimony. So sorry about that, but I'm glad to share a little bit of information that Susan asked me to do, and hopefully it might be a little bit helpful. So the Maine Council on Aging is a broad multidisciplinary network of more than 100 organizations, businesses, municipalities, and older people who are all working together to make sure that we can live healthy, engaged, and secure lives in our homes and communities. And so we've been around since 2012 and are a trusted source network for all issues related to aging in Maine. And as the pandemic unfolded and it became very clear that older people were being impacted at a greatly higher rate than younger people, and that providers, aging services providers, healthcare providers, and others would really be on their own to implement the measures to address challenges of COVID-19. We immediately shifted our attention to understanding the advocacy needs of our members, curating and sharing relevant information, and engaging in multi-sector problem solving, coordinating advocacy efforts on emerging issues, and supporting our care workforce as best we could. Really, during this time, we actively engaged in advocacy with federal, state, and local officials and supported the efforts of local initiatives to respond to the immediate needs of older Mainers. And I think that's absolutely one of the other bright spots that happened in all throughout Maine, which, as we saw, as a lot of older people sort of began staying in place and stopping a lot of the activities that they used to do, was particularly volunteering in the community setting. A whole nother group of older volunteers sort of rushed forward to create all sorts of local community initiatives to make sure that people got access to food, while they were really food more than anything, but their other needs as well, prescriptions. And so, at a time when there was a lot of fear and a lot of confusion and uncertainty, weariness, there was also this amazing thing happening all throughout Maine of people stepping up and building an infrastructure to really ensure that their neighbors got what they needed. So we did all that we could to help those initiatives, fielded a lot of questions from those folks. Can we do this? Can we do that? Can we do this if we're 6 feet apart and we're wearing masks and we're, throughout the pandemic, just sort of constantly trying to get the best information and help advise groups as they were starting this journey of doing sort of really grassroots organizing in local communities. So sort of back to the bigger picture, starting in on March 16th, the Maine Council on Aging started hosting weekly member and partner check-ins. We initially drew between 50 and 100 participants on every call. And these folks really included As Susan said, the aging services providers, so the area agencies on aging, home care, nursing home care, affordable senior housing, senior centers, adult day programs, as well as all of healthcare, health systems, hospitals, geriatricians, behavioral health, as well as municipalities and older people and higher ed and legislators and our members of our congressional delegation. As a matter of fact, I think about 6 weeks into our call, Susan Collins joined us because her staffers were on every call that we hosted and found it so compelling and would tell her about it that she actually came and wanted to hear what others were hearing on our calls. And the beauty of this, sort of being a multi-sector, an opportunity for 1 hour for people to come together was that as the state, as I said, just did a terrific job getting information as it was known, and it was changing just all the time, as we know when this was first unfolding. Well, and even to this day, it's unfolding. But as it was unfolding in the early days, information was being provided really in silos, so that we all got Dr. Shaw every day and we all listened to Dr. Shaw every day. But folks in healthcare were getting updates from Dr. Letourneau and other people in the medical profession, and folks we're getting updates from the nursing home side, from licensing and regulation, and the area agencies on aging. We're getting updates from the Office of Aging and Disability Services. But this was really a time for all of those folks who are getting information within their silos to come together and share that information with each other. And to help solve some challenges that really were pretty big from the early days. Including things like, and I'll just give an example of one of the first things that happened, and I've already referenced that, was that a lot of older people who really are the backbone of Maine's volunteer workforce, particularly with area agencies on aging and the community action programs, a lot of them said, I'm not going to do this. I'm not going to drive for Meals on Wheels right now because it's too risky for me. And so at a time, right, when you had all of a sudden all these older folks aging in place and the federal government saying, we're relaxing all of our restrictions and anybody who's just staying in place can get access to Meals on Wheels, you had at the same time, we had fewer volunteer drivers. And so we talked about that on our calls, the need for volunteers, and our Medicare Advantage plans stepped up to recruit people. A sheriff who was on the call said, you know what, my jail transport guys aren't driving anybody from jail. And so we could probably have them deliver Meals on Wheels. And so they started delivering Meals on Wheels. And a legislator who heard this said, I've got all of these people in Oxford County I can activate. I'll get them to volunteer. And so really within weeks of talking about this challenge of needing volunteers to help deliver meals to people who were staying in place, all of the AAAs saw upticks in volunteers through many different ways, and actually several sheriffs and police departments ended up stepping up to deliver meals during this time, which was really very terrific. Another piece that happened, and I'm cognizant of time, so I don't want to go too far over, was that really early on, so this was still in March, we realized that housing managers and resident service coordinators of properties for older people, housing properties for older people, really had access to no information. They were getting, and they still get most of their information from the federal government. So from HUD and from the federal CDC. And HUD was saying, everybody who lives in your property, is living individually. You can't impede their personal rights So you can't do anything, but otherwise listen to the CDC, and the CDC was saying, shut it down. And so there was a lot of confusion for these folks who were really trying to keep the people, sometimes people, you know, these properties can sometimes have hundreds of people living in them, and really trying to deal with people who were so good, you know, natured. They're, you know, a group of older people who wanted to come together and sing in the community hall in the afternoon to lighten people's spirits, but you know, you couldn't let them do that, and you know, so there was a lot of confusion. So we started a call with Leading Age Maine and New Hampshire. We went to them and said, you know, you've got the best information from the federal, these federal partners, CDC and HUD, and we can be the backbone to host these calls. Let's get a call out there. And so we started getting about 60 to 70 people on a weekly call, initially with housing, congregate housing managers and resident service coordinators, to share information about what they could and what they couldn't do, and what best practices were, how different people were handling it, and eventually we're able to get people like Dr. Letourneau to come and talk with them about what was happening on the ground and how the CDC might deal with an outbreak in a congregate housing setting. Eventually did get someone from the CDC to come and talk with them. And then really cool, we were able to partner with Maine Medical Center to bring 2 epidemiologists to spend an hour talking with them about infection disease control and the kinds of ways they could clean their buildings. We actually had 150 people on that meeting, including folks from actually around New England. We opened it up for that reason, and they went on to work individually with a lot of the congregate housing settings to actually go into the building and do some planning with some of those folks about how best to protect residents. So I'm realizing I'm getting late here on my timing. So just wanted to say, you know, I guess I'll just wrap it up by saying, well, I'll share one more piece about sort of, you know, the other multi-sector piece that we did. We also run the Tri-State Learning Collaborative on Aging. And as we noted with housing, congregate housing, we also noted that a number of other kinds of service providers had no network to support them. And those included volunteer transportation programs, senior centers, and adult day programs. And so we, through the region, started hosting in May resiliency and recovery conversations with those 3 provider types. And we would get, again, 60 to 70 people on the call. And this was an opportunity for them to learn from each other. And it was really great. We would, in fact, try to get the best information we could from all 3 states about what was happening, what the regulations were, but also try to get good information from the federal government on things like, you know, what's the guidance on taxi cabs and Uber for our volunteer drivers in relation to going back to providing transportation services for people. And they were just really terrific. Some of these providers never shut down. Many of them, some of them still aren't operational 16 months later. But they, at each month, would come together and say, all right, we're getting closer to reopening. How did you do this to people who had reopened? Or, you know, we still can't open our senior center, but this is the programming that we're offering. Telephone bingo was very popular, by the way. But, you know, this is how we did it. And so it was just from those little micro things to really big macro issues, an opportunity for people to come together and learn from each other where they had basically no other support. So in closing, what I'm going to say is that we've seen across the country and in Maine and in regions of Maine where you have trusted source multi-sector groups that have come together for various purposes. When the pandemic hit, it was much easier for them to come together and respond to the pandemic as a group, to share information, to share resources, to solve problems together. And so, you know, my takeaway from this time is that we need to do a better job of building those sorts of multi-sector collaboratives across our state. And we saw it just in Aroostook County during vaccinations. You know, vaccinations in Aroostook County went through the roof because they are used to collaborating together and really shared information and gave people the tools that they needed to be able to sign people up through the area agencies on aging up there to get vaccinated. And they just knocked it out of the park while Southern Maine was still trying to figure out how to, you know, stand up vaccination sites. So that's sort of the power of multi-sector collaboration and a little bit of the story of where we've been in Maine. And I think that's about all I've got to say. Thank you for having me.
Thanks so much for being here, Jess, and thanks for fitting us in. I know how critical the testimony is, and glad you're going off to do that good work as well. Susan.
Well, good morning, everyone. I'm Susan Corbett. I'm the director of the National Digital Equity Center. The goal of the National Digital Equity Center is to help close the digital divide here in Maine and across the United States. We are proponents of digital equity for all Maine citizens, and digital equity is necessary for civic and cultural participation, employment, lifelong learning, and access to services. We achieve digital equity by promoting digital inclusion, which includes affordable broadband, affordable equipment, digital literacy, and public computer access. We launched in 2018 and have raised just under $4 million to provide free digital literacy classes and tutoring for all Maine residents, and the funding will last for another 2 to 3 years. I suspect longer based on the need for sure. When the pandemic hit, we were concerned about 3 different groups of people: students who didn't have access to the internet or our families couldn't afford it, remote workers who were suddenly remote workers and didn't have internet connections or couldn't afford it or didn't have equipment to participate as a remote worker. And the group that we lost the most sleep over were the older adults across the state, who were already dealing with isolation and loneliness, and then had to adapt to a stay-at-home order. Older adults that may or may not have had broadband access, or could not afford a connection, or had equipment, or did not have the digital skills to participate in our digital world. We received some funding from one of our funders, and a small amount of funding when the pandemic hit. And we decided to invest that money in a program for older adults. We purchased about 100 tablets. Those tablets connected to a couple of different cell carriers. We said, okay, if you're 70 and older and don't have an internet connection, don't have a device, we will give you this device for 3 months for free. The program was wildly successful, and it spurred multiple collaboration and partnerships across the state. Many of those were older adult organizations, and what they would do is raise some funds for tablets specifically for their clients or patients. And one of our partners was University of New England's telehealthy program. We got tablets into the hands of some of their physician practices to distribute to their patients, and then eventually opened it up to anyone 60 and older. That program actually just ended, so we are really appreciative of the work that we did with University of New England. When the tablets go out, they're fully loaded, including a Zoom link. They are mailed to the tablet recipient. When the tablet recipient receives the tablet, they call our office and schedule a meeting with a tutor. Typically, the first tutoring session is over the phone, and sometimes it's just as simple as, where's the button to turn on that tablet? Eventually, the digital literacy instructor gets the tablet recipient to the point where they can click on a Zoom link, and the next thing you know, they are face-to-face with their instructor for the first time, and you can imagine the pure joy from that moment. We try to then get the tablet recipient to join many of our classes. We have 3 different buckets of classes. One is around work and work in business. So classes like all the Microsoft products or QuickBooks, or for small businesses, learning how to design a pretty simple website. Then there's for home and education. Those are classes that a lot of internet safety, cutting the cord. What do you do when you have a good broadband connection and you can get rid of your cable or your satellite TV? We did a lot of work with teachers and students and learning how to use all the Google products, Google Meet and Google Classrooms, teachers who had not used those tools before, and parents needed to learn how to use them so they could support their students. And the third group is classes called Aging Well with Technology. So prior to the pandemic, we had put together an ad hoc team of older adult organizations in the state. So the Maine Council on Aging, AARP, the UMaine Center on Aging, New England Telehealth Resource Center. And when we met with that group, what they wanted us to make sure is that our classes had an eye on combating isolation and loneliness. And so those classes were already in place before the pandemic hit. Before the pandemic, we were holding those classes online, in person at various public places, senior centers, community centers, adult education programs. When the pandemic hit, we had to move everybody to that online interactive classroom setting, which is why the tablet program was so important. What we didn't want to do is make the digital divide even deeper by leaving behind those novice computer users, including our older adults across the state. The Aging Well with Technology class series includes classes like protecting your online presence, and identifying fraud and abuse, the things that we know that our older adults and novice computer users are most susceptible to. We have classes on connecting, video conferencing, and connecting with family and friends. We worked with a lot of families of older adults who, and help them connect in the video conferencing world, as well as using video conferencing to connect to healthcare providers. We have classes on healthcare with teaching you how to use different healthcare apps. The New England Telehealth Resource Center was really instrumental in helping us develop that curriculum. Those are apps on how to monitor your blood pressure or your weight, or monitor exercise or diet. So there were so many different classes, and many people joined those classes over the past year. I'm going to end with the statistics, which I think is just amazing. Of all of the students that we have seen at the National Digital Equity Center, 58% of those students are age 55 and older. And an even more amazing statistics is, of that 58%, 8% of our students are age 80 and older. And what that tells us is that if you want to learn, you can. So I'm going to put my contact information in the chat. Anyone can feel free to reach out to me at any time. We love partnerships and collaborations, and our goal is to help close that digital divide across the state. And with the help of so many of you, I think we're going to do that. So thank you all very, very much.
And Reed, it's now over to you.
Yeah, I was just given a second in case anybody had a question for Susan. I am going to share slides, mostly so that folks know that they are available to you after the event, because I'm going to be covering a lot of information, but I also would prefer if folks have, if you have questions on certain slides, things like that, that we stop and talk there rather than I roll through all of this. But good morning. I'm very happy to be here. And this has been a fun panel. It's been a fun morning already. I'm excited to see what else happens throughout the day. I'm Reed Plimpton. I'm the project manager for the Northeast Telehealth Resource Center. And I'm here really just to do a flyby of all the things that are going on in telehealth and highlight what areas where I actually think that this, community of action partners, if you will, is really well suited to help inform, where telehealth goes forward. the Northeast Telehealth Resource Center, although we do cover more than just Maine, we are based right here in Maine as well. Myself and a lot of my colleagues are, we work for Medical Care Development, which is a nonprofit public health institute based right here in Augusta. We do have some clinical expertise and some staff out to the University of Vermont Health Network and within their medical center. And combined, we make up Netric, which is one of 14 national or 14 resource centers, I should say, across the nation. This map hopefully helps you look at the way that we're divvied up. So we're the Northeast because we cover New York, and currently we share New Jersey. In the next funding cycle, we actually are, we're giving New Jersey fully to the Mid-Atlantic, although I'm sure our colleagues that we've met over the last decade from there will continue to reach out with us. And combined, we actually all collaborate on efforts and resources for folks as the national consortium of telehealth resource centers, which is some of the links that you'll see here. And one of the other ways that you can always find out how to get a hold of us and what we're up to. There's a lot of text here, and it boils down to the fact that we are here to help. Most HRSA grantees are aimed at the rural and underserved populations and increasing access to care. The Telehealth Resource Center grants underneath the Office for Advancement of Telehealth also have that exact focus, right? Advancing the usage and understanding of telehealth. So one of the things I love about my job is that it covers everything. If people reach out, it is our job to look it up. Or probably the more fun part, connect you to somebody that knows. And so that's something that I actually was thinking about as I pulled these slides together. We have had the opportunity to work with a lot of the healthy aging and aging friendly communities across our 8 states. And as I'll get to in a couple of slides, that has led to your communities, again, highlighting all the ways that I think we at Netric see opportunities for this group to help inform, you know, where are we headed, which is the large question that I'm, again, trying to outline. So as everybody is familiar, both at the state level through executive actions or executive orders rather, and then at the federal level through public health emergency declarations, there has been quite a shift in telehealth permissibility is the word I'm going to choose to use because it covers both reimbursement and possibilities, right? And so if you take anything away from this slide right now, it's just the analogy that I like to use is that there's a lot of toothpaste out of the tube. It has been an interesting year and a half, but it is also important to remember that, you know, a year and a half ago, what everybody was thinking about telehealth was drastically different than how we're handling it. And as things, you know, kind of resume or head towards a new path forward, there's a lot of discussion around what's going to happen. This is stuff that we look at every day. I took the liberty of assuming it's not stuff that everybody's overly interested in this morning. So again, you'll have these slides. I would love to chat with people about it. There actually is a legislative committee hearing in the state of Maine later today about how Maine is looking at updating their telehealth policy for some of these blue Excel columns that you see. I will say that the state of Maine already had one of, in my opinion, I should have added that at the beginning. I'm not a lawyer and none of this is legal advice. In my opinion, Maine already had one of the more progressive telehealth policies in the nation. And we have, as in most public health and healthcare things, we have some great innovators and leaders. So the conversation in Maine is fascinating because it is looking at all these buckets, but it is also less likely to have all of the toothpaste go back in the tube. Sorry, I'm trying to make sure I don't give you my opinion too often on some of these things. It's less likely to have all of its toothpaste go back in the tube because there's already steps that other states are considering, you know, novel and expanded that we already had in place, such as e-consults, which is an asynchronous method that involves you being at one provider and them sharing a photo or some sort of medical record with a specialist that's, you know, in the state of Maine, potentially hundreds of miles away. That was already permissible here. It was not permissible in at least 30 states across the nation pre-COVID. And so that's what I mean when I say that although the hearings in Maine have been fascinating to listen to, and there's a lot of likely changes in terms of what's permanent, the degree of it from pre-COVID is less than in other states. It's happening at both levels, though. Here's some of the federal stuff. Again, most photos that you're seeing in these slides, you're going to be able to click on. It'll bring you to things. Obviously, the blue text is also hyperlinked. And so I just wanted to make sure folks were able to read up on things as they were interested. But shifting out of the policy and more into the exciting and use case type of conversation, I wanted to highlight just the shift in sort of how we've looking at telehealth access as we've interacted with health sites, independent practices, and occasionally, some consumers, patients, so be it. For the past 5 years, past 5 years or so, it has been a little bit of you have to acknowledge the cons in order to be able to look at the pros, right? It's going to be hard for me to talk to a health system about all of the telehealth possibilities if they know their patients don't have access to broadband and they know that they can't get paid for the service I'm talking about. And if I wasn't willing to acknowledge those two things, then we weren't going to be able to talk about the fact that, especially in rural states, specialists are quite a haul. It's quite a day to get to some of them. And that there are, emerging technologies that would allow for a better value-based care system or a more accurate continuity of care consideration, so on and so forth. I forgot there it is. Forgot there's animations on that slide, sorry. Over the last year and a half, it's been all about access, right? As I referenced on the policy slides, a lot of the reimbursement structures changed. It was now, broadly acceptable and almost necessary to be able to meet the patients in their home. And that has been super exciting. There has been a ton of innovation in the medical fields regarding the technology that people were already using in other care avenues, such as there was already a lot of mental health consideration in the private payer market around adolescent mental health interactions in utilizing video games and other online interactions between the provider and the patient. With the flexibilities, some of the folks that maybe didn't have a private payer consideration or a market share were able to try that out. And now the data is starting to come in, and it looks like that's a great, use case for the adolescents. As you look at, actually, I'm going to put a pin in that. As you look at the aging communities, because I'll get to that in a couple slides, I think that there already was enough telehealth going on where the innovation has been a layer deeper than just like, hey, look, we can do this thing. And now it's more thinking about how can we do this thing effectively. So this is really the section that I was hoping to hear from some folks on before, we head to other things, but I know we're kind of tight on time. So I'd love to just follow up with folks if they're interested. Where are we heading? It's hopefully going to be a group conversation, right? These states are looking at reimbursement structures in a way that defers to clinical care as they should. So the provider is going to have more flexibility as to when they think it's appropriate to do a video visit or to do, XYZ telehealth interaction. And so if that is the case, which it looks like it will be, then there's other questions to consider, right? There's still work to be done, even if you move the reimbursement structures. There's digital literacy considerations, there's patient access to technology. And, I am one of many people that's thankful that we have people like Susan Corbett and her team that are looking at these things. And we're really lucky to have them in Maine. There's broadband availability, which there has been quite a push on recently. And we have some great organizations here in Maine as well that look into that. And then there's a lot of other considerations that have bulleted out here. Just to point out that these are all avenues that, again, as I referenced earlier, I hope that various communities get to weigh in on with their providers, with the health systems. I know that some of the health systems in the state, just from recent conversations, are looking at patient feedback as ways to determine what percentage of video visits remain post-pandemic, what percentage of, routine check-ins versus, emergency needs and things of that nature. And so with that, now we're to the exciting part. It's important to remember that we really have been doing the off-the-shelf, the video stuff, right? Like right now, I'm using a plug-in camera, but I could be using the one on my laptop if I really wanted to be directly within that red circle. There's already a ton of use cases in Maine that use some of these other things that are more like health center to health center, or, primary care practice to specialist offsite, that maybe aren't relying as much on a relatively strange broadband network or on relying on getting the digital capacity fully across the state, because there are happy mediums that can be put into play, right? And so a field kit is a box that covers, peripherals and remote patient monitoring. Remote patient monitoring are devices that, connect to the individual, that you take the reporting, the MyChart considerations out of the equation for some care avenues, whether it's chronic care management or, post-op follow-up, things of that nature. The telemedicine cards, I mean, these are, there's a ton of them. There's a ton of options, which is what's really exciting. I have one here behind me to show health systems. And one of the things I like about it is that it is truly adaptive. So it can be built to what the health system needs. So maybe it doesn't have all of the peripherals, which some of the fancy ones like this guy over here do, but it's a lot cheaper. And it's also movable. So sites don't have to dedicate one room, whether it's a long-term care facility or a private practice or whatever it is. And that was all just pre-COVID. And this is the stuff I was referencing when I said I wanted to put a pin in it. The healthy aging and the aging friendly communities and so on and so forth across our region have been active, as you've heard on this panel, and it's been where I've gotten to learn about a lot of cool things here. So in the, I'm just going to go left to right. So if you're looking at this sort of tin box, if you will, that's actually in the state of Delaware. I'm going to a webinar tomorrow to learn more about this. That is in their libraries now. They have, Delaware and Rhode Island, for that matter, utilize libraries for some of the community classes that Susan referenced, and that other, groups in our state do. And so those community classes had a ton of innovation to do over the last 15 months. They wanted to do the cooking classes for their patrons. They wanted to do whatever it was, and they had to figure out how to do it through Zoom. And so they have, as a community, gone through enough of a learning curve that they're now like, there's a happy medium to be at play here. And by putting a digital access point in their library, there is somebody there to help with any tech issues. You're not putting it fully on the individual to figure out the new tablet that their son bought them. This is somewhere that they could go to the librarian and ask them, hey, I can't quite figure out how to get onto, GoToMeeting that my provider wants me to use, because I usually do Zoom. And so I think that's a great happy medium. Next to it is smart pill bottles. That's actually, I will admit, that one and the one next to it, those are European use cases. But I'm excited and I'm optimistic always. And so that pill bottle is, it would automatically connect with your provider if you're like myself and you have a prescription that needs to have provider approval before refilled, or directly to your pharmacy as you get to your refill date, taking one thing out of the equation in a very busy life that we all lead. And I think that's awesome. The hydrogel, that is something that, you could get if you're in a PT setting or something like that. And so that it does sort of like the muscle stimulus that you would have to do, with your physician after some sort of PT session. But you can now leave and it'll do it for you. And then, so to the point in the chat, high tech and low tech is meeting in the middle. That's what I'm all about recently, is I do think that we have to keep that in mind. But I also, to the point of the tablet in the bottom left here, I think it's recognizing where high tech is also needs to be innovated again, right? So the GrandPad, this is the company, and I don't often call out the company because I'm not advocating that you go out and buy one. I'm more just referencing where you can find this research. That tablet has been designed with more sensitive touch sensors that are built to be more accurate for a finger that has less moisture in it. Because as we age, as we all age, even myself, as young as I am, I have less moisture in my finger than I did when I was 12. And so an iPad and, all of the devices beforehand are built for, one user. And there's variability in devices that needs to be sort of thought about. And so this is the first group I've ever seen do that. And I think it's a thing that we're going to see, kind of proliferate across the spectrum. And then the Be Kind RI thing, I wanted to call it out because I think it's something that this folks in this community are probably already doing. And I'd be happy to have you meet these folks as to figure out how they got their website. But this is, the healthy aging groups in Rhode Island. They connected with Nesterly, which is just a national company. It's sort of an Airbnb type thing, actually. And they developed sort of a call and request volunteer form to, to continue capitalizing on the aging population that wants to be a a volunteer and a resource for their community, and to get those people help that maybe it's hard for them to figure out a way to submit quickly. And so this website is literally bekindri.org, is where you can both sign up and request, and they're hoping to add more and more to that. And so those are all innovative things I'm super excited about. I hope everybody is as well. I am going to skip some of this stuff. This is all here. You can reach out to me. It's sort of just hammering home that there is a lot of stuff up in the air and worth the conversation around when considering how telehealth works in all aspects of the lifespan. And if you take away one thing from my presentation, hopefully it's that you think you should be a part of this conversation, because you should. Teletech things to consider. There's lighting differences just between me and the people that were on the panel today. And, you know, that gets to the whole left bucket or the right bucket. But there are things more, there's more to it than just launching the video visit. And that's on both the provider and, you know, the people that interact with the community and the consumers to help them learn and to make sure they feel prepared for it so that they're able to do it. I think all of this is already starting to bubble up. That's one of the cool things as well. Finally, to the point of what I do all the time, we're here to help. We've been developing some new resources over the last year. We are fortunate enough that due to the increased demand in our efforts last March, we got additional funding with the CARES Act. And so we have been working with, you know, community stakeholders across the 8 states to identify resources of need, you know, like some of what Susan Corbett mentioned that we collaborated on, and some of the things that you see here. I am not the host of the Maine bi-weekly telehealth office hours, but Danielle Lauder, who some of you know well, and who some of you may get the chance to meet if you decide to go, is, and I'd be happy to point that out. We've been hosting those for a little over a year in most of our states. It's just a chance for people to ask any type of telehealth question. I threw this slide in just at the last minute because, Susan, I thought you were going to cover it and I didn't want to duplicate. If you are experiencing broadband difficulties right now, or if you don't have broadband, or which would be a little unlikely because you're here, right? If you know people that don't have broadband that need it, there is currently a federal governmental program that will subsidize part of your broadband services given, I think there's 6 qualifications. I didn't put those qualifications on here because there's already too much text on this slide. If you qualify for the FCC Lifeline program, you qualify for the Emergency Broadband Benefit Program. There's a lot of other stipulations I'd be happy to walk you through. But if you're interested, you know, the links are here. And so it's up to $50 a month off your broadband connection, and some internet service providers are also offering a one-time discount for connected devices. And so getemergencybroadband.org is where you would apply. And like I said, this is something I'm happy to help you out with. We are quite literally listed as a resource, which is why I scrambled to throw it in my slide deck. It is going to be open for the foreseeable future, but I would encourage you to start checking it out now in case you need any application stuff to be pulled together, so on and so forth. And then the last stipulation I'll add on that is this is offered from the government to the internet service providers who chose to participate, to the patrons. And so that's an important thing to consider, because you would want to look at this link where it says here and identify which broadband providers in the state of Maine have agreed to participate in this program. And in the spirit of full disclosure, there are areas of the state that don't have a broadband service provider that could participate. So there is still, again, work to be done. And we're happy to, you know, here at Network, we're happy to kind of learn from folks and see how we can do that. Here's some other resources I thought people might be interested, looking specifically at the aging friendly population, more broadly, patient and client resources. Susan's links here, but I threw it in the chat as well. Again, other resources. If you're interested, we are cautiously optimistic that we're going to be able to return to our normal in-person event. So if some of what I talked about today got your attention, or if you just want to learn more about telehealth, please reach out. We'd love to have you. We'll be in Manchester, New Hampshire in September. And you can contact us anytime. I threw my other colleagues on there as well, because some of you may know them, but if you don't, you're more than welcome to reach out to them. We're happy to help.
Yes, we will. Thank you so much, Reed. And to the person who just asked in the chat box, yes, these slides, like all the slides from today, will be made available. Nan?
And in their defense, I haven't sent them those slides yet. So
Okay.
they'll be made available as soon as I hit send on this email over here.
Hence, the future tense will be available. So take it away, Nan.
Okay, how about a deep breath, everyone? I feel like I've been drinking from a fire hose for a fair bit. It was nothing like starting the morning with a sprint. And I just want you to take a minute and relax. We're going to move into some breakout rooms. There will be anywhere from 8 to 10 minutes in a breakout room. We will ask that you elect a moderator / timekeeper and a scribe. And when you think about who's going to be a scribe, we want someone who is good with a computer or a tablet to take dictation essentially, and then we'll put them into a word cloud to see what everybody says, because to have everyone go through a readout can get a little bit monotonous. And I think visuals are always better. So without further ado, you will teleport yourself into or you will be teleported rather, into a breakout room. And there will be people who will pop in to make sure that you have selected a timekeeper moderator and a scribe. The prompts for this breakout room are in the chat. You can see them now. We're looking to know what you have missed over the last 15 months. What were the bright spots in that? And what did you learn? I'm sure that you might have new skills, be it sourdough, bread making, or Zoom. So take it away, Lorena. So now we're going to turn to infodemics. And we have two speakers on that topic. The first is Jen Gunderman King, and the second is Joy Baresi-Saucier. I hope I didn't butcher that too much. And hold on. Let me just say that I missed my second screen here. There. So Joy is the executive director of the Aroostook Agency on Aging. It's a nonprofit serving Aroostook County since 1972. Joy began her career as a registered nurse, and then she later received a master's in health administration from St. Joseph's College of Maine. She's board certified in healthcare management and a fellow at the American College of Healthcare Executives. And for over 25 years, we won't say, I'm sorry, for over 25 years, Joy worked in a variety of healthcare positions, from patient care to community education, fundraising, and executive leadership. She joined the Aroostook Agency on Aging in 2017 as an executive director, and she's president of the Maine Association Area Agencies on Aging. And she's a member of the Development Committee for the Maine Council on Aging and a board chair of the Aroostook Regional Transportation System. And she's dedicated to ensure that Mainers have the ability to age in their chosen home communities. And then Jen Gunderman King is the Maine AHEC director and a faculty member at UNE. She coordinates and participates in interprofessional community and population-based education, and her practice focuses on rural and underserved areas. She's been a member of the Peace Corps. She's a Maine health epidemiologist, providing technical assistance to Caribbean and African countries on HIV surveillance. She loves epidemiology and using data to make discoveries about health issues in communities. So she's really quite an expert on infodemics, as you'll learn about shortly. So without further ado, I'm going to stop sharing and turn it over to them.
Hi, good morning. I think I am first up to introduce the topic of infodemic, and I have a number of slides that I will not fit into 15 minutes, but I will share those slides with Nan and others that can be sent out with any conference information. Thank you for having me. As Nan mentioned, I have a background in infectious disease epidemiology, and I've, over the past couple of years working at UNE, I've been a little bit distant from working in epidemiology. And so whenever I have a chance to talk about infodemics, I just get really excited because I get to go back to my roots and talk about something that I am so passionate about in terms of data and public health practice and using evidence-based interventions to make a difference in our communities and in our world. So I am going to provide sort of like infodemic speed dating for us all this morning. Again, I will share my slides, and my information I think is available if anyone has any follow-up questions or comments or wants to talk more, because I am a data geek and I will take any opportunity to talk about this stuff. So I'm going to share my screen this morning. And again, sort of the purpose of my presentation is kind of lay the land of what the infodemic is. So I'm not going to read this definition, but to kind of highlight a couple of things. An infodemic, according to Merriam-Webster, is basically a blend of the word information and epidemic. And the part that I highlighted here is that it is rapid and far-reaching spread. And it can be accurate and it can be inaccurate information. We're going to focus today more on the inaccurate information. And what I love about this definition is that infodemic is not officially in the Merriam-Webster dictionary. It is a word that they're watching because it is being used so often. The word was actually first sort of used in the context of public health and health back in 2003, when a journalist used the word to describe really the amplification and replication of misinformation and disinformation related to SARS. And what I really love about what this quote directly from the journalist, he says that, you know, it's a few facts mixed with fear, speculation, rumor, amplified and relayed swiftly worldwide by modern information technologies. What I find so interesting about this definition for infodemics is that he said this back in 2003. That is 1 year before Facebook was launched. It is about 3 years before Twitter was launched and about 13 years before WhatsApp was launched. So already infodemics was a topic before we had what we have now for social media. Before we go any further, I just want to clarify a couple of terms here: misinformation, malinformation, and disinformation. So misinformation is usually false information, but not really an intention to harm. On the other end, we have malinformation, which is genuine information that's intended to harm, such as leaks, harassment, hate speech. And in the middle, sort of shared, is disinformation, which is false information intended to harm. So when we talk about an infodemic, we particularly talk about misinformation and disinformation. And this is kind of the graphic that I like to use when I want to provide a visual around infodemic. So we think of a cough and the germs that we spread, very timely as we are still dealing with the pandemic. That false information starts as a little bit and it grows and it spreads, and at some point it even breaks off and can create its own, like, another outbreak. So why do people misconceive with misinformation and disinformation? And Claire Wardell, who co-founded First Draft, says, you know, that happens for 3 particular reasons. People want to have financial gain, so they spread misinformation and disinformation. It means they're going to make some money. There's going to be political gain, meaning they're going to gain some power, or there's just going to be experimental manipulation. So someone just wants to send some misinformation, disinformation out there just to see what happens, what type of anxiety could be created, what it leads to. So there's really not a whole lot of gain except for, you know, for the sake of almost entertainment. And really, I'm not going to go into this model much, but this is a model of what's called the theories of behavior change. you know, in public health, we often think, well, as long as I give out the correct information, action's going to happen. But no, we go through some stages before we actually implement some behavior change. And the thought here is that myths and misconceptions and misinformation and disinformation enter at different parts of these stages. But when that misinformation enters at a point when we're going from not thinking about an issue to kind of thinking about the issue, it can really change the way that we act. And why is this a problem? Well, the World Health Organization, the United Nations have come out, particularly around COVID-19, and said misinformation is hurting us. It is a problem. It is hurting people's physical and mental health. It's also threatening things such as economics, about it's increasing stigma. It's really preventing us from moving forward with evidence-based prevention and control measures. So how do we know it's happening? This is just one graph. And this shows a professor at a University of Michigan, I believe it is, looked at the number of media reports in India that said that spread some misinformation. And you can see there was a dramatic spike, particularly near the beginning of the COVID-19 pandemic. In public health and epidemiology, when something becomes an outbreak, it means there's a dramatic increase in what's more than expected. So we know, we know that there's always going to be rumors. We know that there's always going to be some misinformation that's spread. But it's when we see that dramatic spike, we know we've got an infodemic on our hands. So this information comes in many forms and sort of shapes and sizes. What Rutgers had determined with the University of Oxford is that about 59% of this misinformation, disinformation, is information that's reconfigured, meaning there's a little bit of truth to the information and it's manipulated and twisted to become dis and misinformation. And then about 39% of it is completely made up, completely fabricated. For example, bleach kills germs. That is truth. Take bleach to kill germs inside of your body is a reconfiguration, right? There's some truth that bleach kills germs. Should we be ingesting it or injecting it? No, that's a reconfiguration of the truth. And then there's some things that are completely fabricated, such as getting a vaccine inserts a microchip. We've all seen misinformation out there. We've all have observed it. Someone may have sent it to us. We might have just seen it in the news headlines, but we've seen it. So in epidemiology and public health, we start to think about, okay, who is most vulnerable? Who is at highest risk? Like, what does it look like? What are causes and contributing factors? So this is, again, this slide is not to make a political statement. This is the way that the data was collected. And what I would say the most important thing to take away from this graph is that people over the age of 65 are at higher risk to share fake news, misinformation, and disinformation. And there's a number of reasons for that in terms of how quickly misinformation can spread. There's been a few other studies to help us understand misinformation and disinformation and how it is amplified and replicated. One study looked at risk factors. This study that was done by a number of universities, some of the conclusions that they came to was that people under the age of 25 were most likely to believe mis and disinformation. It showed that people of racial and ethnic minorities were more likely to not be able to necessarily discern. They were more unsure about mis and disinformation. They really couldn't see it as not true, but they were unclear if it could actually, like, it was just some lack of clarity. And one of the other things that this survey showed is that there could be an association between instant messaging apps and the spread of misinformation. And when we talk about instant messaging apps, we're talking about Messenger from Facebook, and we're talking about WhatsApp in places and technologies such as that. Some other common sources, again, these are not to make political statements, but this is what the research has indicated, is that in the United States, at one point, specifically near the beginning of the pandemic, the #1 source of mis and disinformation was Donald Trump at the time. And then another study showed that while social media played a role in amplification and replication of information, the really sort of crux of it were those instant messaging apps. So just a little bit more evidence that the Messenger, WhatsApp, those ways that you get information and can quickly send it out to a specific group in a very quick and timely manner were very concerning. This other study that was done more recently really was sort of one of the first pieces of research that I saw that actually said, you know, this misinformation spread is happening on social media. It specifically looked at Twitter, but it even took a step further and said that people who were, if we look at the second bullet, people who are exposed to news media associated with fewer misperceptions. So if you were exposed to media, you were less likely, you were more likely to comply with social distancing than those people who saw misperceptions on social media. So social media was now, the misinformation and disinformation that was being spread in social media was actually somehow potentially being associated with health behaviors that did not help to prevent and control COVID. So we saw how this misinformation was more than just about spreading wrong knowledge. It was actually resulting in some risky behaviors. So what can we do about it? I'm just going to kind of go through these because I think Joy's going to talk a little bit more about it. There's actually a lot of information now about what we can do to prevent mis and disinformation from being spread. There's a lot of things that can be done at the individual level, educating about considering the source, checking your bias, understanding where you're getting the information from. There's lots of really good news that people really turn to their healthcare provider for information. Like that healthcare provider, regardless of your background, like that's where people still report going for information. That's hopeful. There's actually some things that we can also do in an individual level. There's this great game out there now called Go Viral. It takes about 5 to 10 minutes, and it can help you understand how quickly your decisions on social media can spread information. There's also a lot of work that's being done around combating the source. So how to report misinformation on different social media platforms. And the World Health Organization is helping to promote that intervention. There's ways that we can just correct false information. That does not always solve, when there's people who can be very passionate about the mis and disinformation that they believe and spread, but there are populations who just need the correct information. And then in public health, we need to really implement interventions that are appropriate for each group. I think about my dad in this circumstance. My dad is 75 years old. He did not finish high school. He is challenged with his literacy level, and he is very vulnerable to mis and disinformation. I have seen it happen with him on many issues, but my dad wears a mask and got vaccinated because for him, the motivating factor is to be able to see his grandchildren. He's to the point where he will go to a convenience store in Massachusetts, and if someone's not wearing a mask, we'll tell them that he's going to take a picture of them and send them to the government. Like that's how passionate he is about his prevention and control measures. But his motivating factor is he wants to see his grandchildren. So how do we tap into those motivating factors to make sure the correct information is spread? There's a number of other resources. The BBC has a great video called Stop the Spread. It's actually not Stop the Spread about COVID. It's about Stop the Spread of mis and disinformation. And in public health and in healthcare, we need to treat infodemic as an outbreak with urgency, with resources, with good data collection, involving many different people. And so for anyone who's read Malcolm Gladwell, The Tipping Point, this quote really summarizes probably everything that I can say about infodemics, that the tipping point is that magic moment when an idea, trend, or social behavior crosses the threshold, tips, and spreads like wildfire. While infodemics focuses on that happening with mis and disinformation, we can do that with correct information. We can be that tipping point to be an advocate for correct information. So with that, I am going to transition it over to Joy. So thank you.
Thank you, Jen.
Thank you, Jen. I have to admit that infodemics, the term infodemics, are you able to see my screen? Yeah, is a fairly new term for me. And so I was just so excited to get to hear Jen share that perspective, because when Dr. Weary talked to me about this and I saw the term infodemics, I actually had to go look it up, because that's not a term that's used that I've used before. So the perspective I'm going to share with you today is one that comes from a community-based organization. The other thing I'll just reference in opening is that there are 5 agencies on aging in Maine. We're very similar. We provide many of the same services, but we're also unique. So some of the things that you hear about today may be available in your local agency on aging, and then some may not, but they may have other things available as well. So hopefully today what we can do is just give you a little overview of a perspective about how do we provide accurate information to those living in our home communities. And I always start my presentation talking about home communities because it's a much clearer link to what we do at Agencies on Aging. So I always ask people, what is your home community? What do you declare your home community? And for me, I actually have 3. I have my home community where my mom lives, where I grew up. I have my home community where I live now and I've raised my children. And I have a future home community. I'll be moving back to my husband's home community this fall, where my in-laws live, and they're in their 80s, and we're moving to be closer to them. So home communities are very important, and not just to us, but if I asked all of you, I'm sure that you would all say that you want to continue to live in your home community too. And not only in your home community, but in your home. And that's what research from AARP shows too, that living in home communities is very, very important to all of us. And so that links to, what do Agencies on Aging do? Well, we help people live in their home community. This is our formal mission, but really comes down to helping people live in their home communities, like a lot of other community-based organizations do as well. And many of you do in your work every day in whatever sector that you're working in. Just a quick note on Agencies on Aging. These are the core services that we all provide. And there are over 600 agencies on aging around the country. So if you're not in Maine, if you're attending from somewhere else, I'd encourage you to check out your agency on aging too. And you can see a big part of what we do is related to supportive services, especially information and assistance. And that's my link to this. You're seeing my screen, correct? Just a head nod from someone. Yes, okay. So infodemic, again, I had to go look it up. This comes from the World Health Organization. Too much information, including false or misleading information, just as Jen said. And the interesting thing, as I listened to Jen and thought about this coming into this presentation, is that certainly we've seen this with the COVID, but don't we see it every day with many other topics as well? And certainly in our line of work we do here, this also comes from the World Health Organization, which I thought was interesting, because when they talk about how to manage infodemics, and they talk about good health practices, these 4 types: listening, promoting, understanding, building resistance, and engaging, empowering communities, is really what we do every day in community-based organizations. So I think it's a very nice, I was very happy to be asked to present today by Dr. Weary and others to say, how is this playing out locally? So how can we make a difference? A few things that I'll share about Agencies on Aging and how we're trying to make a difference related to infodemics in our community. Certainly all of us are Aging and Disability Resource Center, which is through the No Wrong Door movement. That's really the core of what we do, is information and assistance. we not only have what we call an answer line, where I say you don't even need to know the question you ask, you just need to know your need. But we also in our region have outreach staff that are positioned throughout Aroostook County. And if you aren't familiar with Aroostook County, I like to, it's a huge county, of course, but another way to think of it is that driving from Allagash to Benedicta is like driving from Bangor, or it's farther than driving from Bangor to Kittery. So it's a huge geography, and we have outreach staff scattered throughout that geography to help us to connect with people where they're at and understand what their needs are. And information and assistance plays a huge role in the needs that we see in our community. COVID has given us some challenges, but also some opportunities to connect related to information, misinformation, disinformation, specifically about the vaccine. In our case, we started receiving calls in January, and those calls really went through May for assistance with vaccine enrollment. So we mobilized in partnership with our traditional healthcare partners and our public health partners, we mobilized about 50 volunteers to help people start enrolling for their vaccine. And I have to say, this was a very, very taxing on us because we had to do this sudden shift, but the outcome was amazing. The relationship that we have with volunteers in our community, that we could get 50 to come. There were days when we might have, we have a big conference room. There are days we might have up to 12 volunteers there on the phone all day calling people and helping them enroll. But the connection that we have with those that we serve was amazing, and so much of an opportunity, I would say, to provide good information and answer questions. And you can see that we had over 2,800 calls during that period of time for those looking for help. And this is a very rural community. I mean, we only have under 70,000 people live in our whole county. We also, like other community organizations, provide a significant amount of education. And a couple of the two top ones I just wanted to reference, because again, there's oftentimes misinformation related to health insurance, Medicare, Medicaid, and also related to fraud and scams. And so we do provide a resource for that. All agencies on aging do that as well. We have a variety of evidence-based wellness classes. We have a variety of classes to help us in partnership with our healthcare partners to become more age-friendly. We started something called the Online Gathering Place, which was is a weekly online place where those with early onset memory loss, or I should say memory loss, early stage memory loss, and those with chronic conditions can come to gather. Again, an opportunity to provide good information on a variety of topics and provide a social opportunity as well for those that are presenting. And also through the COVID, we launched an iPad lending library. So we've partnered with Susan that you heard earlier. We will provide an iPad, lend an iPad to anyone participating in any service of ours so that they are able to participate. And so that includes all this educational work, but also caregiver services and prevention of readmission to hospital type services. I think another thing that we need to do is innovate, and we've done that, and we're doing that in our organization through something called our Friendly Volunteer Program, which is a demonstration project through the Community Care Corps, which is focused on how to use volunteers to meet some in-home needs, preventing admission to institutional settings. And there were only 23 sites that were funded across the nation. We happen to be one of them, so we're very excited about that. So we have a slew of volunteers. We have friendly visitors and callers who reach out and provide social connection to the community. We have friendly helpers that can do everything from helping with a load of laundry to shoveling someone's steps, but we also have some specific helpers that can help with money minders, paying bills, dealing with mail, technology helpers who are now helping people learn how to use technology and how to set up their cell phone or set up Zoom for a healthcare appointment. And also something new is called Friendly Neighbors, where we're embedding trained volunteers in communities that can act as a first contact for someone with a concern, or can identify someone at an early stage that might have a concern. So this type of innovation and how do we stay connected and expand our services through the use of volunteers, I think is a really important resource that we have to combat infodemics. These volunteers that we have that have helped us with COVID or helped us in friendly volunteer situations, they are they're so skilled, they're wonderfully skilled, and we provide additional training to them to ensure that they have the best information possible. And the last thing I want to mention is that we have worked with our communities to activate them to become age-friendly communities. We don't lead age-friendly communities at the Agency on Aging, but we have partnered with the AARP and others, Humane Center on Aging, to provide good information to communities about how to get started on the age-friendly journey. And I think the connections that are provided through age-friendly communities across the state, we have over 70 in Maine now. It's an amazing network of age-friendly communities with good information being shared between communities that then can come out and help others in the community. So this is actually a picture of Danforth. This is a bingo size class with a group down in Danforth, which is at the very southern part, just on the border of Aroostook County. So I'd encourage you to take action today by contacting your Agency on Aging to see how you could partner with them, what information they have available, how to access their services most easily, participate and become a volunteer, or consider how you can get volunteers involved to be helpful in spreading good information. Consider getting involved with an age-friendly community or starting one in your own community. And I'd also encourage you to reach out again to your Agency on Aging. There are 5 agencies on aging in Maine. You can see we all cover pretty large geographies, but it's as simple as a call. And that's what I always say, just starts with one call. Give us a call and we'll see how we can work together to provide service and combat infodemics. With that, I'm happy to take questions.
Does anyone have any questions? I think we can probably take 1 or 2. We might, if you want to put them in the chat, if that's easier for you. It's different. This section was certainly different content than the first 2. With the first section.
I have a question.
Sure.
Given the various differences in how people experience someone coming to their door, how have you handled going into homes where the receptivity might be not as good as in other homes?
Yeah, I think that for the most part, although we didn't, in Aroostook County, we stayed open the whole time. We did minimize, specific to COVID, we minimized going into people's homes, and only if it was an emergent situation. We tried to do everything else through phone, or we even last summer had folks that would meet in parking lots or meet in someone's driveway, but in terms of if people want to go to the homes again, I think that it's really up to the relationship we establish between our worker and that person. With home delivered meals, we went to a contactless type of delivery where we would deliver to their porch or to their steps and ask them to have a cooler there so we could put the food in that. So with COVID, that's been different, but I will say that we have other situations where there, for example, are insurance salespeople that may go to someone's home unsolicited or without an appointment. And we do get calls about that. We do get calls to ask who is this person and why are they coming to my home and how does that compare to what I have for a current insurance policy, for example. And those are calls that we do receive.
Okay, we're running short on time. We have a quick question about bingo size. I'm feeling like it's Twister with a twist, but maybe not.
Well, bingo size is a new program that actually we were able to bring to Maine through a grant that we have with UNE. And I'm going to get the state wrong. I believe it's Kentucky. It comes from Kentucky. We are the first organization in Maine to offer that, but for those interested, we can put you in touch with our staff here that provide that. It is a mix up of bingo and exercise and movement and a whole lot of fun with prizes. And we've only just started. We've, I think, just done one class or maybe on our second class, and we've had a tremendously positive response to the program.
That's great. That sounds great to me. So without further ado, we're going to move into the second breakout session. You'll go back to your same rooms. You may change up the roles. And this breakout is to look forward. We've talked about what we've lost. We've talked about what we've learned. But now we want to think about, what do we want to take forward in the future? Is it Zoom? Is it something better? What can we do to bring those who may be reticent to join us to, grab our hands and come along with us? So you'll have 30 minutes again. You have 4 prompts, but now you know the drill. So this should be pretty fast. When you're done, come on back to the main room. If you need help, reach out. So let the teleporting begin. We have Fran Seeley and Dr. Jennifer Monti who will be speaking next. And Fran Seeley was born in Ireland. She moved to California in 1964. She has a BA in English and a master's in education administration. She moved to Maine in 1999, not yet a native. She's a foster grandparent in the Portland school system. She chairs the Opportunity Alliance Senior Volunteer Program Advisory Advocate Advisory Board. She's an advocate for issues impacting adults so that they can live independently. And Dr. Jennifer Monti is a cardiologist at Maine Medical Center. She's interested in the intersection of medicine, public health, and invention. Before she started medical school, she spent 3 years in the tech sector. And in 2015, when she was a cardiology fellow, she co-founded a company to focus on a problem with non-invasive hemodynamics. So I'll let her tell you about that. She established the innovation cohort at Maine Medical Center for physicians, faculty, and staff. And she's a board member of the Maine Technology Institute Biotech Advisory Board. So we have 2 people coming at these issues from very different perspectives. And I'm looking forward to hearing what they have to say. So without further ado, I'm going to stop sharing. And Fran, why don't we put you up first?
Hi, I'm Fran Seeley and I live in Portland. And when Susan asked me to join this panel, she had heard a poem that I wrote and wanted me to read the poem. And this poem was written to the people at NDEC. We heard Susan Corbett earlier today. NDEC of Maine was really just a lifesaver for our volunteers. When COVID struck, the foster grandparents in our program and the senior companions in our program were not able to volunteer in person. We have over 100 volunteers. The foster grandparents volunteer in schools, senior companions volunteer with other older adults to help them maintain independence in their own home or wherever it is that they're living. And about 1/3 of our volunteers were somewhat familiar with technology or had access to devices. And the other 2/3 would have been totally isolated from each other and from their clients or the students that they volunteered with. So NDEC not only provided a loan of tablets, they also provided individual or small group classes in the use of technology. And I think Susan explained, in some cases, it was just simply how to turn the machine on and then how to use it. And I'm still availing of the classes at NDEC. But anyway, this poem I wrote rather in April, which is National Poetry Month, and we were celebrating that as our volunteers as a group. And this was a way of thanking NDEC. So I'll read the poem first and then get into a few ideas about what I think is needed for older adults in the use of technology going forward. Reconnected, and it feels so good. Pandemic, pandemonium, life turned sideways. Stay-at-home order, social distancing. How to connect? Virtually, I'm told. Me, I'm too old. Zoom, they say. But with whom and where, when I can go nowhere? A tablet will help. Oh no, not another pill. A tablet to use for Zoom, and boom, you'll be united with family and friends. There's no end to how to meet. Yet I'm lost. It's too hard a feat for non-techies like me. Help! NDEC to the rescue. A troop of tutors and teachers armed with abundant knowledge and boundless patience teach me that a mouse doesn't need legs. Windows don't just let in light. Operating systems are not for surgery. Clicking is not made with one's tongue. Google has nothing to do with eyes. The cloud is not in the skies. Bites are not for eating. A Mac is not a burger. Apps, log in, log out, RAM and ROM, docs and scans, Wi-Fi and wireless. Am I in Jetson land with Jetson speak? No, this is my new reality, my virtual connection. Thank you, Alex, Bethany, David, Ina, Lisa, Louis, Marcy, Taylor, Tina, Tom, for opening the Zoom room door, for showing me how to explore the far reaches of cyberspace. Now that poem, I think, illustrates where many older adults were at the beginning of the pandemic in relationship to technology. And I'll use an example. I had a friend who at the end of 2019 had hip surgery. She was 91. So from January through March, she was still recuperating at home, had no family anywhere near. So I was helping her, bringing her to follow-up appointments, doing her shopping for her, taking her shopping, taking her out to eat. And then pandemic struck. I could no longer bring her in my car. That was not allowed. So I did her shopping for her, getting her list the night before I would go. And she was getting more and more depressed because I couldn't take her places. I could go visit her with a mask. I wasn't even supposed to be in the building unless I was a real medical person going in, but there was no other way to get to her. She needed to talk to her doctor. Couldn't understand why she couldn't see her doctor. when she called, usually she got the receptionist, who was always very nice and helpful. But my friend had severe hearing impairment and used a Captel phone. So while somebody is talking to her on the phone, she's reading aloud what she's hearing. So the person has gone on to the next phase and she's still reading the first one and then gives up. And her frustration with the technological part of connecting with her doctors was very, very severe. I would be there with her and help her. But if she called somebody, and I would often get a call from her at home and saying, I tried to call so-and-so, and they gave me all these things to press, button 1 and button 8, and I don't know what buttons I'm supposed to press, and they're talking too fast. And then I would go and help her with it. She's only one of many who have to deal with this kind of inexperience with technology, plus physical limitations on a daily basis. If she were alive when she would have had to sign up for a vaccination, I don't know how she would have navigated it. She probably wouldn't. And again, living alone was tough on her. So the impersonal aspect was what was bothering her. Could not understand why her doctor could not see her. So for her, even post-pandemic, telehealth would have been really a trial and a difficulty. The confusion that it caused and the depression that it caused, it was sad to see it. Not all of our older adults are in that same situation. But as I said in the poem there, you know, just the language of technology for older people, that can be a barrier. And I was thinking of some of the things that were challenges for our volunteers who are representative of our older adult population. First of all, computers, tablets, smartphones are too expensive. Many still have a track phone. That's all they need for emergencies. The internet connection is too expensive. You know, granted, you can sign up to Spectrum or whatever carrier you wish, and you'll get a great introductory offer. And at the end of 12 months, the prices go through the roof. The fear of the unknown about using devices, that's a big hurdle. You know, how do I connect with this thing? And even the techie language and terms, they can all be a deterrent. You know, like I said in there, RAM and ROM and scans and docs and everything else, you know, it's all like a foreign language. And as we get older, we kind of tend to think we're not really able to learn anything new. And that's totally not true. And the fear of failure. You know, I've heard people say, you know, I really want to be able to do this so I don't embarrass myself when I talk to my grandkids. You know, they don't want that fear that I'm so old, I really can't do this. A lack of self-confidence. Will I be able to do it? Maybe I shouldn't try. You know, somebody else can do it instead. That notion again that they think they can't learn something new, or it's just too overwhelming. A lack of access to effective training. I was very fortunate, as were all of our volunteers, the staff at our foster grandparent and senior companion program got the resources for us. They put us in touch with NDEC. They put us in touch with UNE. They put us in touch with Cyber Seniors, with Southern Maine Agency on Aging. And there were all sorts of programs that people could tap into. And for many of us, because we were able to use technology, we were able to continue some of our volunteering online. Normally, I volunteer 40 hours a week in person with kindergarten in our local school. Now I can at least do about an hour a day with these kindergarten kids. I've never met them in person, but we have a bond. I did a pen pal project with them. I would write a letter to each one of them. They would write a letter back to me. And it was just so great. And then I knitted scarves and mittens and hats for them. And they got those in their letter.
Fran, I'm going to ask you to hold off for a minute. I know that Dr. Monty is time crunched, so let me give her a few minutes and then we'll come back to you if that's okay.
Sure. Yes. Sorry, Dr. Monty.
Not at all. I learned so much by listening to you talk about your work and your point of view, so thank you. Thank you for inviting me, guys. I don't think I know many of you. My name is Jen. I'm a cardiologist at Maine Med, and I just wanted to offer a couple of some points of view from my side as a provider side. Initially this was thought of as sort of what's coming in technology, and as I arranged my thoughts, I realized that most of what I think is valuable, or the questions that are valuable here, actually aren't about technology themselves. They're about a couple of sort of social and cultural challenges, some of what Fran already identified here, about how we can make some of these important changes stick. And for me, I care for patients from all over the state. Some are from Portland, very savvy. Others will come down from the Canadian border. And I also have a remote clinic in North Conway, so have a good sense of different populations. And the one topic I keep coming back to is, how will our communities across the state respond to possible new entrants as providers? And this, for me, gets right at the problem of the labor shortage. Physicians are included in there, that we can't serve the population as it stands, and there likely are to be new services that pop up, or telehealth that is independent of the health systems. And I wonder how people will be interested or willing to engage with that as those come online. The second thought I had, and you've all hit right on it, is this question of broadband is the whole ballgame. So the most valuable thing we probably could do is organize for advocacy around the very specific bills that are going through the Maine House and Senate now. And then the third point I had, as I think about how we care for patients and populations, is how do I, as a doctor, specialist, right, break up with people, right? Get more towards minimal medicine or minimal medication or minimal interaction, because at some point that's diminishing returns. So I think that's a neat conversation to have with our patients who might benefit from having fewer people, not more people, involved in their care over time. I did make a couple of comments here, a little bit more on the techie side, about what I think is coming and what is interesting. The first, I think, is the sort of promise of remote monitoring. And cardiology has been ahead of the game for years because we implant so many things. But I would say a lot of what we see for remote patient monitoring is largely noise. It's not a lot of data that helps me take better care of people. So I think it's coming, but I don't think that we're there now. And I think the devices, like Fran says, it's too expensive. They've not been built yet for scale into homes. So I am sort of cautious of recommending or engaging with some of the remote patient promises right now, because I think they're only in a few specific cases are they valuable. We really need like a leap in sort of the quality and the type of data that those devices provide The other thing I think is so neat, and it's not a technology, but it's a different way of thinking, is trying to get at the problem of emergency access. So we have an ambulance problem, right, in the state of Maine and New Hampshire that I serve, in getting to people urgently. And there are whole systems of transport that are developing in other places that would love to hear about the problems we have here, and they would set up here and they would help solve that problem. Another one that kept coming back to me is this problem of what technology do we really want in a home? And one that comes up for me is something called an AED. If you know what those are, these are the kind of shock devices you can find in Target and you can find at the airport. Well, most people who have a big problem are at home, right? But we don't have those devices at home, but we could, because one is just about to be approved by the FDA. So this to me is all to say, people are inventing all of this stuff without a really pronounced sense of what people actually need. And this happens all the time. They put millions of dollars into development of these really cool things. They think we're going to solve all these problems, and they fall flat. And they fall flat because they don't call Fran in advance, right? Fran and 20 of her friends to say, this would never work, right? So I get very excited to be invited to a conversation like this, because that's what has to happen, right? We need to have an identifiable cadre of the willing that says, I will look at new things coming through, and we want the truth. And if we do that enough and offer the community as a place that wants to engage with companies trying to help, they're probably going to build something better and smarter. While Fran was talking, I wrote down here, I speak too fast for older people. And I'm saying to myself, what can we build to help with that? Right? If my voice coming through Fran's phone can be slowed down 50% or 60%, have we bridged a gap? Right? So sorry, I'm a little bit pressed for time, but that's what I want to leave you with, is this idea of please, it's really an appeal to say, please help us on the technology side, build smarter things so we don't waste your time and money and continue to have these sort of frustrated gaps, because you're actually the most valuable people in the process. I think that sometimes gets lost. So I will, so thank you.
Jen, thank you. I couldn't agree more that we have to look at a problem rather than a solution to fit the problem. Too many times of my former job of 1-800 your product sucks is all about the wrong technology for the problem that they're experiencing. So I'm pleased to see it. I think we're going to have Fran's band of merry, what do you want to say, experimenters at the ready for all of the work that you're doing and others in the state. I think it's something we should really think about doing.
Yeah, absolutely. That would be a great consortium so that companies say to themselves, where do I go to learn most quickly? I'm going to go to Maine, right? We're going to call up to Portland and get a group of 100 together. That's also where companies want to live, by the way, right? As we're connecting what is healthcare, what is people, and how do we grow this economy so our young, they want to live and learn most quickly. And if we develop a very transparent infrastructure for that engagement, that's really attractive to young people.
All right, I think we have our marching orders.
Thank you, guys.
Thank you all.
Thank you, Jen.
Fran, would you, I think Dr. Monty's going to head stage left. 2 minutes. Okay. And Fran, maybe you want to respond to that? Maybe you want to sign people up on the dotted line right now?
Well, I don't have that power, but there's, when you were talking, Jen, about, the devices or whatever it is, the physical limitations as we get older. I'm thinking of like arthritis. To have an iPhone and to be able to hold it and use it is, it's almost impossible for somebody with arthritis. So devices that would be user-friendly, or likewise for failing hearing, failing vision. I know, like on Google Meet, when I read for the kids, I can reduce my playback speed so that things are going slower. Mm-hmm. Mm-hmm. And, just to have that on every device for an older person. The other thing too is teaching people the value of technology. And we mentioned this in one of our breakout rooms, you know, getting people interested in technology in something that means something to them. Maybe it's a Zoom call with their favorite grandchild, and they see how that works. And then, you know, gradually introducing them. So then maybe a Zoom call with their doctor is it something that's,
You know,
a
Fran,
little
one thing
easier.
I want to make sure I say before I go is that one thing in the legislature right now is actually a bill to make just audio calls reimbursed on par with the Zoom, because there's not that much added value often in the Zoom part of this, and that's where you get tripped up.
Yeah.
So, I mean, a phone call that's solid, you know what I look like. If you're not having active symptoms or a lesion I need to look at, we got to bag that part and still be able to be rewarded for the communication, which is where the value is.
Right. Yeah. Yeah.
I'm going to hang up, guys. Thank you so much for inviting me.
Thank
Thanks,
you, Jen.
everyone.
Sure.
Okay. So I'd like to, it's just one now. People are beginning to drop off like flies, which is, I understand. So what I'd like to do is do one quick piece of housekeeping, which is to say that emails with an evaluation link will go out tomorrow, and the certificates will go out on Monday. So Lorena, I hope that that was all I needed to say to you. I really appreciated these 4 hours. I felt like I was drinking from the fire hose the whole time. A ton of information from everybody's perspective. The slides will go out as we get them to you. And I think I would like to encourage you to make friends with the people who were in your breakout rooms or next to you on the Hollywood Squares, if you don't know them. I think that there's a lot of possibilities for our people to be the testing ground for new technology. I think we know what we need to have, a whole lot of flexibility and patience, hand washing, and a few other things. So Dr. Wary had to also attend to some other business, so she's not here. I'd like to thank you for attending. I'd like to ask you to think about whether you'd like to do this again sometime, maybe before the year is up, to figure out what a focus might be. So with that, I'm gonna go mute and thank you for your time. And okay.